So she was sitting at her desk at work when it started. A single hiccup, then another, then another. By the time she drove home that evening, it had not stopped. She was in her late 30s, working a desk job, living an ordinary life. Her days were routine, her health unremarkable. There was nothing in her medical history that would explain what was about to happen. The hiccuping started on a Tuesday. It did not stop for 5 weeks. In the first few days, she assumed it would resolve on its own. Most hiccups do. The normal reflex lasts minutes, occasionally hours. Hers lasted through the night, through meals, through sleep, when she could manage it. She tried every home remedy documented in common knowledge, holding her breath, drinking water upside down, a spoonful of sugar, a paper bag. None of it worked. By day 4, she made an appointment with her physician. Her doctor ran a standard workup: blood panel, chest X-ray, basic neurological assessment. Everything came back within normal limits. She was told it might be stress. She was told it would likely resolve. She went home. The hiccups continued. By the second week, the physical toll had become significant. She was not sleeping more than a few hours at a time. Eating had become difficult. Each hiccup is a sudden, involuntary contraction of the diaphragm. When that happens, hundreds of times per hour, for days on end, the body begins to wear down. She described the exhaustion as unlike anything she had experienced before. Not sleepiness, something deeper than that. She returned to her physician. A referral was made to a gastroenterologist, then a neurologist. More tests were ordered: a CT scan of the chest and abdomen, an endoscopy to examine the esophagus and stomach, blood work specifically checking for metabolic abnormalities. Everything returned normal. If every test came back normal, perhaps the physicians were right. Perhaps this was psychosomatic. Perhaps her body was doing something her mind had triggered. She began to wonder, as many patients in this position do, whether she was the problem. She had no name for what was happening, no explanation to offer her family, her employer, the colleagues who had begun to notice. She simply kept hiccuping, and nobody could tell her why. But here's what made this case different from everything doctors expected. The hiccups were not random. They were rhythmic, consistent, and completely refractory to every standard intervention the medical team had attempted. This pattern, documented hiccups persisting beyond 48 hours, has a clinical classification that most people never encounter. Intractable hiccups. That is the medical term for hiccups persisting beyond 1 month, though the designation for persistent hiccups begins at 48 hours. It is not simply a prolonged version of an ordinary reflex. It is a distinct clinical condition with its own set of causes, its own differential diagnosis, and its own treatment protocol. Clinicians classify hiccups in 3 categories: acute, lasting under 48 hours, persistent, lasting 48 hours to 1 month, and intractable, lasting beyond 1 month. Her case fell at the edge of that final category. The hiccup reflex itself is one of the least understood reflexes in human physiology. It serves no known biological purpose in adults. The reflex arc involves the phrenic nerve, the vagus nerve, and a hiccup center believed to be located in the brainstem. When this arc is disrupted or overstimulated, the diaphragm contracts involuntarily and rapidly, forcing air against a suddenly closed glottis. That is the sound. The question, in cases like hers, is what is triggering the arc in the first place. In the medical literature, documented causes of persistent and intractable hiccups include gastroesophageal reflux disease, central nervous system lesions, metabolic disturbances, certain medications, and in some cases, psychiatric or psychogenic origins. Her imaging had shown nothing structural. Her metabolic panels were unremarkable. Researchers and clinicians working with her began to focus on a less obvious possibility. The vagus nerve, the longest cranial nerve in the body, running from the brainstem through the chest and into the abdomen, was a candidate. Irritation along the vagus nerve pathway can trigger the hiccup reflex without producing findings visible on standard imaging. Clinicians noted that her endoscopy had revealed mild esophageal irritation, not enough to explain 5 weeks of continuous hiccuping on its own, but enough to consider the nerve pathway as a contributing factor. Treatment options for intractable hiccups are limited. Medications including chlorpromazine, haloperidol, baclofen, and gabapentin have documented use in the medical literature. None are approved specifically for this indication in most countries. Each carries its own side effect profile. Her treatment team began a carefully monitored medication trial. The results were partial at best. The frequency slowed. It did not stop. And then came a finding that changed how physicians understood this. What eventually worked was not a medication. It was a procedure documented in the medical literature as effective for vagal nerve stimulation, digital rectal massage. First described in a case report published in the Journal of the Royal Society of Medicine, the procedure involves stimulation of the vagus nerve through the rectum, interrupting the hiccup reflex arc. The report, widely cited in medical circles and noted in popular science publications, described the technique resolving intractable hiccups when all other interventions had failed. In her case, according to the clinical record, the hiccups stopped. The response was immediate. After 5 weeks, the hiccuping ceased. What had not responded to imaging